Top Med Talk.
Hello and welcome to Top Med Talk. I'm Desiree, Chappell, your host. And as this coronavirus pandemic continues, we are continuing our conversations with care providers around the world to continue to shed light on the crisis. Now, our series COVID from the Frontline highlights healthcare workers who are on the ground and some those who are playing more supportive roles. And we want to share their stories in hopes to provide education and support for all of our global listeners. Now, recently we recorded a podcast with several military, Air Force, National Guard representatives who are on the ground in New York City in the epicenter of the COVID pandemic here in the U.S. And one of those individuals was Captain Joel Sherwood. Now, Joel and I had a conversation around, or part of our conversation in that earlier podcast was discussing life after COVID and how we maintain or possibly institute more stringent guidelines around enhanced recovery and perioperative optimization. So I'd like to welcome Captain Joel Sherwood back to the Top Med Talk podcast. Hello, Joel.
Well, hello. Thank you for having me again. It's always a great honor and appreciate it.
It is. These conversations, Joel, have been long overdue. We've always said we would do something. So I'm glad that it's now. I'm sorry it's maybe under these circumstances, but I think it gives us a great opportunity to talk a little bit more about what we both are very passionate about, enhanced recovery.
Absolutely. I think the timing is probably more important now than ever. Absolutely, Desiree.
Yeah. Now, Joel, just for our listeners, if they didn't listen to that earlier podcast, can you give them a little bit of your background and what you're doing up there in New York City?
Sure. I'm a registered nurse of 20 years. My background is in critical care, cardiac cath lab, as well as medical science liaison for Pacira Biosciences, and that's on the civilian side. I'm also a United States Air Force officer and reservist, and on April 4th was activated and given approximately 48 hours to deploy on a C-5 Galaxy military aircraft to the epicenter, New York City. And I've been here for approximately, it's been almost a month now.
And Joel, that was strictly voluntary, wasn't it? I mean, when you're in the National Guards, I guess they call everybody up, but this was something that you kind of volunteered for?
So for the Air Force, there was a request put out early, I would say late April, that asked for those individuals that were currently already involved with the epidemic in their own hospitals, where they were already on those front lines. And in my current role, that was something I was not actively engaged in. So it allowed me the opportunity to volunteer, but absolutely volunteer for the opportunity. I was very passionate as I felt like I was sitting on my hands watching New York City being overwhelmed by this unseen enemy and definitely wanted to be a part of the response.
Oh, yeah, absolutely. And we thank you so much for your volunteering in those efforts, Joel. Thank you for your service, because I think from our previous conversation, hearing about really the godsend that it was that you could come into New York City in this situation as part of this large force. What was it, about 200 from the Air Force and another couple hundred from a couple other branches of the military to come in and provide relief and respite and support for those who are on the ground?
So there are multiple sites. There's the Northeast sites that are involved where we've had multiple convention centers that have been transitioned into makeshift hospitals like Javits, New Jersey, New Orleans, I believe also in Boston as well. And between medical personnel and non-medical personnel to make that happen, I want to say that's somewhere in the ballpark of 15,000 individuals. Approximately 1,000 plus of those are of medical orientation. It is a huge undertaking that we've gone into here. New York City just happens to be the one that has the majority of individuals involved for obvious reasons.
Well, it's amazing that they could activate so quickly and have everything, really have a relatively good plan to get in there and start helping out. I know, again, we'll signpost people to go back and listen to that podcast because it was great to hear about the experience and what your colleagues, everybody's bringing to the table to get some of these field hospitals up and then to provide support. And Joel, I can tell you from my experience, I know it's really hard to kind of feel like you're sitting on your hands. I mean, I'm a part-time nurse anesthetist or CRNA, really, not being on the front line at this moment, but fortunately for me, having Top Med Talk to help continue to educate people again around the world. I know how hard it is to feel like that. So again, thank you for volunteering and stepping up and getting your nursing skills back in back in shape.
And I think, though, that your part is definitely important. As I go to multiple conferences, multiple CRNA conferences, and your name is something that is known out there. And I think your program has been very helpful to kind of keep everybody aware. As you know, data studies take a while for practice to change. And sometimes these type of editorials and podcasts are kind of the frontline news that you get. And in this particular response, we've certainly learned, as approaching this from ARDS versus COVID-19 protocol response, that more than ever, there's a need to hear what is currently working and adapting very quickly to that.
Yeah. Now, Joel, one of the things that I think has come out of this that we feel is really important is to continue the conversation of patient care now that we're kind of moving, not that we've moved completely beyond COVID, obviously, but we are seeing the numbers start to decline. We're still having to take care of the COVID patient. But there is going to be life after COVID or during COVID that we are resuming elective cases and starting to, bring people back into the hospital. And like I said, one of the things that we had talked about on the earlier podcast was once we start bringing people in for elective surgery, how important it would be to really maintain or really improve enhanced recovery after surgery, those guidelines and principles that many of us are using to ensure that all of us are using them in an effort to get these patients in, through, and out of the hospital as quickly and without causing any iatrogenic harm or exposure to nosocomial infections like you said before. So can you tell me a little bit about your experience with that and your thoughts on that?
Sure. I think for one, we should always be thinking in terms of the potential of a resurgence, and especially with a historical perspective, a potential baby boom 9 months from this time frame. We're right back in that same period. As General Schwarzkopf said many years ago, the more you sweat in peacetime, the less you bleed in war. Upholding some of these practices that we've learned is very, very important. So I think strategy and how we approach patient care is going to be important. I think that thought leaders are probably going to provide some perspective, as they did in the early onset of the COVID-19 pandemic, related to time and exposure, thinking about in the OR space, the utilization of N95s and other masks. And then the deeper dive is, okay, beyond the OR, what does that look like down the line of care? The registered nurse, the respiratory therapist that enters the room, is there a means to reduce exposure? So for example, with euvolemia and hydration, I would hope that those things are continued. Otherwise, me, the RN, going back into that unit has to maybe have to go back into that space to diurese that patient through furosemide. Is it the opioid minimization, where part of the enhanced recovery protocol may be removed for different reasons and potentially increase utilization of antiemetics, where now I'm going back in to contend with nausea and vomiting, which may not only be the initial going back into that room for that nausea and vomiting, but maybe repeated exposures of going back into that space. And then from a patient perspective, if the patient potentially is in the hospital longer because of adverse events associated with opioids and not having that prime opioid minimization that many hospitals have worked so hard to obtain that reduction, does that mean more time and exposure to them and potential for cross-contamination and nosocomial infection?
I recently did a lecture for the Office of National Drug Control Policy through the White House on enhanced recovery and, reducing opioids through these quality improvement initiatives. And the big takeaway from that was utilizing a multidisciplinary team to get these programs up and going, and then devising these opioid-sparing techniques, not necessarily opioid-free, but that is a component of it, opioid-free, opioid-sparing, multimodal pain management schemes that we can reduce opioids for those reasons, like you said, reducing antiemetics, reducing uncontrollable pain. And so that increases the workload for all of these people. And that's a really fair point. We really want to reduce the amount of times that we're having to go into these patients' rooms and potentially infect them or infect us. So valid point that I hadn't really thought about there. When it comes to opioid reduction in general, and these different multimodal pain regimens, it's been really interesting to see how much opioids have kind of crept back in the care of COVID patients, for sedation and some other things. Do you think that that's going to maybe derail a little bit of the enhanced recovery initiatives as we go forward?
I certainly hope not. So much effort and energy has been placed into these different programs, sometimes taking over a year to get full buy-in by all the different stakeholders and full adoption to where there's a return on investment, as you know. And I have seen and heard where when you're kind of at wartime and things are very chaotic, there becomes a prioritization of what's important. But hopefully that won't be the case, but rather looking back again at time and exposure, if we're able to continue the adoption of different single shot blocks, the ability to continue those scheduled non-opioids that have been part of some of the guidelines that have been put out, does that mean that we reduce the workload for, say, the registered nurse with the PCA pump otherwise they may have had to manage, or that catheter elastomeric set that maybe has like an ambit pump or a CAD type setup where you have an anesthesia provider that has to step back into that space? And is that really the best use of that individual's time? I think one of the lessons learned from COVID is people that maybe were an orthopedic surgeon, or even I've seen a pediatrician, or even downgrade like CRNAs having to go to the ICU to work as nurses, that there was a lot of adjustments that people had to make. So I think bandwidth is something that has to be taken into consideration for the potential of these things coming back. Again, things may appear to be normal in the next few months, and things may return back to normal. But the adoption of that enhanced recovery, I think, also should be mindful of that potential for resurgence and being able to maximize everyone's time to be able to potentially go back into those crisis kind of roles that we had to do on this particular round.
Yeah, that is such a very fair point. I just, again, hadn't really thought of it from that perspective. Just really managing that, and hopefully if we can send someone home without, with managing their pain successfully, that's one of the benefits of utilizing these principles all together and the synergy of them. Opioid reduction being one, maintaining their fluid management and hemodynamic management being another, that we can get them out of the hospital and they don't even have to stay if we can send them home and they don't need constant revision or constant pain meds that they can't deal with outside of the hospital. So yeah, anything we can do to get them in and out and get less exposure for everyone is sure important.
Absolutely. And I truly hope that is going to be the attitude going forward. We've always known in the hospital there's that potential for nosocomial infection. And one of the best ways to manage that is to optimize individuals before they come in the hospital, right? Which I'm hoping that too becomes a focus with things like our total needs and other procedures where BMI, A1C may be more controlled to give that better chance for success in the hospital. But also looking at the things that have come out of this as far as telemedicine and being able to do good preoperative education as well as follow-up postoperative through these means that maybe had been rejected prior, that maybe that we didn't think folks were maybe tech savvy enough, or maybe we didn't want to put the energy in that space. Whereas now that's kind of been forced upon us. And maybe that can be an enhancement to the already developed enhanced recovery program. Kind of like the patient navigator that we see in some programs.
Oh, absolutely. We just had a wonderful conversation with Carol Peden and Bobby Jean Schweitzer as well about implementing and utilizing telemedicine in the perioperative space. And how, a lot of PAT clinics, they'll do calls and things like that to kind of triage people through to say, we could do this over the phone, or we really need you to come in because we need to do further tests. And so I think having that opportunity to reach people via telemedicine, and now that everyone's going to be used to doing it, and I don't think technology is going to be a barrier, and we're going to be able to overcome some of the other challenges that initially, were really impeding the huge scaling and uptake of this. Like I said in the last podcast, we have such an amazing opportunity in the next month and a half, even 2 months, to really get a hold of our patients that had been postponed or canceled due to COVID, that we can reach them and start doing these telemedicine pre-op optimization visits, Because, you can get in to see your endocrinologist for a telemedicine if it's your A1C is way out of whack. I know that there are anemia clinics that are opening up, and there's an opportunity for that as well, again, through telemedicine and working out all the fine details that way. And all you have to do is come in just for your infusion. So lots of great learning points and things that I hope we can take away from this. And again, just to push that home, it's about pre-optimization, but optimization during and after surgery as well to optimize these patients and get them back to baseline more quickly, or hopefully even better than baseline where they were before.
And what a great time to do it, because there are a lot of folks that have downtime. I don't want to phrase it as downtime in the respect of they don't have things to do, but certainly with multiple state medical boards putting elective cases on hold and our government agencies putting out stops to elective cases, what a great time to maybe take advantage of some of that telemedicine and optimizing those individuals, if at all possible. Because I wouldn't say concern, but my wonder is when COVID-19 has resolved, or things become more open to having these patients come back, and it looks like that may be sooner than later, what does that look like for us on the hospital side, who are going to potentially get a mass of patients? Because now you're looking at 2.5 months where folks haven't come in. That doesn't seem like a lot of time over a 12-month period, but different patients have different acuity and needs for that surgery. And there may be a second wave here of folks coming into the hospital needing to get their treatments done. So I think that's going to be the importance of throughput, not just from an opioid minimization standpoint, but just the ability to get these patients through the hospital, but while still providing quality care. It may be necessary as far as getting that next bed open, that next OR table open for that patient that's been patiently waiting for 2+ months to get on that table.
Yeah. And what a great time right now, because I know many of us at home who are, many have been furloughed. Many have, not lost their jobs, but definitely been laid off at this time. And what an amazing opportunity to do a little bit more education about this, do a little bit more reading, pick a topic of patient optimization for surgery if that's in your wheelhouse, and study up on it and implement that whenever you get back to work. I mean, I think it's a great time for us to do a little bit deeper dive on some concepts and ideas that we maybe not really felt like we ever had the time to do before.
I couldn't agree more. I think in the initial 3 weeks that there was some downtime for myself. I caught up all my CEUs and read up on some of the papers I've been wanting to catch up on. And to your point, those individuals that are passionate about moving the curve on patient optimization and improving patient outcomes, what a great time to improve your readiness if we take a military point and going back and executing on some of that knowledge that can be obtained during this period. Absolutely.
Yeah. I love it. Improve your readiness. That's great. That's what we that's really one of the things whenever I lecture about enhanced recovery is that, the military works because everybody does what they're supposed to do, and it's very strict guidelines. And enhanced recovery, I mean, we protocolize, we standardize the way we do things because we want to reduce injury, reduce complications, and, really truly standardize what we're doing. So it's a good takeaway from the military.
Absolutely. And you certainly don't know if that's going to be your wingman that's going to be on the table next, or your mom, your sister, or any of the other Americans that we fight and protect for daily. I think that global perspective, whether it be COVID-19 and taking proper social distancing precautions, or the patient that's in the hospital for elective procedure and being mindful about the total opioids they receive and those other aspects to enhance recovery, that we're protecting one another. And then I hope in this COVID-19 pandemic that there is a larger community that's developed in response to this, as we see people with their pots and pans and cheering at the 7:00 hour outside their windows and serenading one another. That part of that song can be about the looking out for one another in the hospital as well, and getting mom or dad, brother, sister back home sooner and in better condition as a result of our efforts. I think all of that is really important.
Absolutely. Joel, I can't thank you enough for taking more time out of what I'm imagining is a very hectic and crazy chaotic time frame there in New York City. So I really appreciate anything you can give us in this wonderful conversation to help maybe move the needle when it comes to enhanced recovery, especially after COVID. So thank you so much.
Well, I appreciate you so much and what you do for the enhanced recovery community, if you will. There are so many of us that listen to your program, your perspective, your clinical background, and having this media and stage for individuals like myself to share just a little bit of the knowledge, hopefully will collectively make a difference out there. I really pray and hope for that.
Wow. Thank you, Joel. That's a sweet compliment.
Top Med Talk.
And thanks to our listeners so much for sticking with us during our coverage of COVID from the front lines. If you want to find more, hear more, we will put those links to Carol Peden's podcast as well as Bobby Jean Schweitzer in our show notes. So we'll signpost you to those. But you can check out all of our different areas that we focus on, perioperative medicine and optimization of surgical patients at topmedtalk.com. That's topmedtalk.com. You can also follow us on social media, Twitter, Facebook, LinkedIn. We're there. Please stay safe, stay well. We're all in this together. We're going to get through it. Thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.